to do. With that, I'll go ahead and introduce our first speaker. Dr. Amy Ives is an assistant professor at the University of Maryland School of Pharmacy with a practice in internal medicine at MedStar Georgetown University Hospital. As an assistant professor, Dr. Ives' responsibilities include co-director of the Skills Laboratory and course manager for the institutional skills-based laboratory curriculum for second-year Doctor of Pharmacy students, where she has championed the use of the electronic health record in the curriculum. Additionally, Dr. Ives has recently converted the third-year Skills Laboratory course into an APPE readiness course with a focus on written and verbal communication skills. As a clinical pharmacist at the MedStar Georgetown University Hospital, Dr. Ives runs the Inpatient Anticoagulation Stewardship Program and is a co-chair of the Interprofessional Anticoagulation Stewardship Committee. So with that, I'll turn it over to her. Thank you.
So while we're getting started, I'd like everybody to go ahead and log into Slido. You can scan the QR code or log in. That will be part of our presentation today in terms of the polling. I am going to remove my mask for speaking purposes here. I am in the 6-foot zone, so hopefully that'll make it easier for everybody to hear me. Thank you, Dr. Deb, for the invitation to speak today for Teaching Excellence Day. Much like it's not advancing here. There we go. All right, much like my path to becoming faculty, this lecture might be a little bit non-traditional in terms of teaching excellent day topics. It does speak to some of the efforts that I have initiated since I've been here at the School of Pharmacy, but I spent many years as a practitioner, much like you all, prior to becoming a faculty member. So I have seen both sides, whether that be, what a preceptor expects from a student or a resident versus what a faculty member trains a student to do. And I've always been fascinated by the dichotomy. So there is this gap and a nod to a bucket list trip that a few faculty members actually took in 2019 pre-pandemic. I'm calling this Mind the Gap. And that is the holes between the curriculum and practice. So we're going to go through some of those topics today. I've selected just a few. There we go. I've selected just a few to talk about. So we're going to start with the learning objectives. We're going to talk about entrustable professional activities and what role that has in training our students. And this is particularly relevant to residents who are in the classroom. Give me my, something's wrong here. It's missing a poll question. What's happening here? There we go. Okay. So go ahead and fill out this question. Basically, I'm asking who is here in the audience today. Are you a resident? Are you a first-year resident? Are you a preceptor? Or are you a faculty member? There we go. Wow, look at this. All right, some preceptors and PGY1 residents, which is great because this topic is designed for you. This next poll question, depending on who you are, if you're a resident, you're going to answer from the resident's perspective. If you're a preceptor, you're going to answer from the preceptor's perspective. And the question is, the one thing that I wish I knew if you're a resident, or what you wish students knew prior to coming on rotation. So these could include things like specific skills, things that you have noticed that seem to need additional work, something that the curriculum might be able to help you out with. Deadlines now matter. I like that one. There's no excused absences. Communication, we're going to be talking about that at the end. That is one of the #1 rated valued skills by preceptors and employers alike. If the preceptors don't know everything. I like it. LexiComp. I like that one too. We tend to favor micromedics here, but I'm a Lexi girl myself. Gray areas. This is good. So we will be addressing some of these, and part of the purpose for me presenting this topic today is to let you know some of the changes that have been made in the curriculum recently that will address some of these issues that you have all identified. So we're going to start by talking about the continuum of pre-APPE readiness, which is the curriculum, APPE or advanced pharmacy practice experiences, and then entrustable professional activities. And as you can see, I have these listed here as individual items, but you need blue and yellow to make green. So this is really a continuum, and each layer is based on the foundation that is presented before. So the curriculum is obviously the responsibility of the faculty in terms of making sure that students are ready to go out on rotation. For APPE, right, the APPE experience that falls to the preceptors, many of faculty are also preceptors. And then the entrustable professional activities are the responsibility of the graduate. So when you leave the school, these are the activities that you are being entrusted to perform. We're going to go into that in a little bit more detail. Okay, so a nod to our dear friend Stuart Haynes, who published this article on entrustable professional activities. I believe it was in 2017. There are 6 domains of EPAs, and in those 6 domains, there are 15 entrustable professional activities. So this is really mind-blowing. Think about this. So you're sitting down to write the units of professional practice that are defined as tasks or responsibilities that trainees are entrusted to perform unsupervised once they have attained sufficient specific competence. This is across all areas of pharmacy. So community pharmacy, health systems pharmacy, ambulatory care, all of those areas. So think about that, trying to write entrustable professional activities or EPAs and coming up with only 15 of them.
People or
yeah, that's what I mean. I just mean it's never snarky or cynical.
This is it,
So for the people that are online, I think somebody's microphone is off. Is there a question or something we can help you with? So of the 6 domains, the one that we're going to talk about today is the practice manager. And in that domain, there are 2 EPAs. The first of which is oversee pharmacy operations for an assigned shift. So this includes things like supervising, training, and educating technicians, maintaining policies and procedures, addressing drug shortages, maintaining inventory and the budget. We're not going to focus on that section. The one that we're going to talk about, though, is to fulfill a medication order. And just as a reminder, an entrustable professional activity is that a legitimate authority has entrusted the resident or student to perform these activities. So this is a legitimate authority, such as the school, they graduated you. NAPLEX, they said that you can be a licensed pharmacist, the State Board of Pharmacy. It could be your employer. Any one of those individuals has said, we are entrusting you to perform these functions unsupervised. And that's kind of the key here. So just for all of the PGY1s that we have here, how do you feel about fulfilling a medication order? Are you able, because we're kind of right at the beginning, so this is perfect timing for this, are you able to verify a queue of medication orders? What are your thoughts on that? All right, show of hands. How many people feel comfortable handling a queue of orders right now? Okay, are those my PGY2s over there? And I know one of you, so you better be raising your hand, exactly. So think back to a year ago for the PGY2s, right? How did you feel? And this is one of the areas that I want to spend some time talking about, because think about fulfilling a medication order. This encompasses a number of things, right? So you have IV orders, you have PO orders, you have, all the things that are on this slide, determining the contraindications, drug interactions, and very interestingly, because this encompasses all areas of pharmacy, we have determining a patient's copay, selecting the most cost-effective medication for the patient, addressing assistance programs or any prior authorizations that are required. So we typically think of this as a community pharmacy issue or an ambulatory care issue, but this is becoming a health systems or acute patient care issue as well. So in the hospital, how many of you are addressing prior authorizations or selecting medications that patients can afford prior to discharge? Excellent. Talk to me. What are you doing? Can you turn on the microphone, please?
So in this past year, I guess as a PGY1, we did several prior authorizations for patients who were going home on fidaxomicin for C. diff infection.
Excellent. Okay, fidaxomicin, what else? I saw somebody's hand up over here. What are you doing?
I feel like I did on internal medicine services, we did a lot of DOACs to make sure that we know which one the patient is covered.
Excellent. That's what I've been involved with most recently. I've been working with a medical student for the last 6 weeks, looking at this specific issue, DOACs on discharges. And honestly, I'm stunned by the information. Maybe I'm a little naive, but roughly a third of our patients have insurance-related issues, whether they have no insurance at all or they're underinsured, so they can't afford their copay with prescription drug coverage. It's just unbelievable. And really, I think, kind of an opportunity for health systems pharmacists to get involved with direct patient care. Okay, so we're going to start kind of at the big picture and work our way down. So we're starting with the end in mind. What do we want our students to be able to do when they graduate? That is, we want them to be able to fulfill the medication order. So we're going to talk about what does the advanced pharmacy practice experience standards say about fulfilling a medication order. And this was very interesting to me. So there was a 2014 study that demonstrated, no surprise, that there was a huge variability in APPEs, right? So a student went to experience A and a student went to experience B, and they had completely different experiences. And most importantly, this was in the distributive functions for health systems and for community pharmacy. So those were the two areas where there seemed to be the most discrepancies in terms of experiences for students. So the American Association of Colleges of Pharmacy developed a task force to create essential elements for the required rotation experience. And just as a reminder, the required rotations are community pharmacy, ambulatory care pharmacy, health systems, and inpatient general medicine, or what we call acute care. So those are the 4 required rotations, and they set out to create basically these recommendations that all students who go through these experiences should have these essential elements as part of their experience. What is absolutely mind-blowing to me is that they never reached agreement on health systems pharmacy. So they could not confidently say that across the United States, that students would be able to meet a list of essential elements that they created. So what they did to address that was a follow-up survey. They had an 88% response rate, which is pretty good. It was about 123 schools of pharmacy, and they surveyed the experiential learning directors of those programs. And the criteria or the essential elements that they came up with, so they presented those elements and they asked for agreement on those elements. And that was accurately verify a new medication order, accurately prepare a medication order, and sterile compounding. And so the majority of respondents agreed with these, the first two, but not with sterile compounding. And I don't think this is any big surprise because there are so many resources and requirements in an institution to allow people to make sterile compounds that is not routinely an experience that you're going to give to a student, right? And so that was just, they turned that statement into a pre-APPE readiness experience only, and this could be a simulated experience, but not a requirement of the APPE experience. The areas of controversy from this survey were the use of the word verify. So in other words, do we give students the opportunity to verify medication orders in an electronic health record system? I would bet that we do not. So if anybody online or in the room precepts students for this experience, let me know how you address this particular issue. So respondents had an issue with the word verify. Supervising technicians, again, so you're verifying the work that has already been done, and sterile compounding. So I know in our laboratory series, we made a move a few years back to kind of create a more real world experience for the students. So they spend the first year making IVs and doing the sterile compounding, but then in the second year, they are approving or verifying products that are already prepared. So we give them these little baskets and everything is all completed and they're basically checking like they would supervise a technician, because we felt that that was closer to what a pharmacist does in hospital practice. So what does the community pharmacy essential elements say? And this is very interesting because it says to accurately apply the prescription verification process. So they define that as the receipt of the prescription. So you're looking at the prescription to make sure that it is legal and can be dispensed as it's written, and then utilize a computerized pharmacy management system for safe medication distribution to patients, which sounds an awful lot to me like an EHR, right? So we have this for community pharmacy, but we don't have this for health systems pharmacy. Isn't that strange? That's very strange. So now we are looking at what the UMB APP experience looks like. So we've talked about, the governing body, AACP, what they have said should be covered in APPE experiences as essential elements. Now we're looking at what do we do here at the University of Maryland. Interestingly, there are two required experiences that fall under this conversation. The first is health systems pharmacy practice, and the other is acute care medicine. Those experiences are very different in terms of their responsibilities. So the health systems pharmacy practice is really about the distributive functions, how the health system works, budget, inventory, management, things like that. And the acute care rotation is all about patient care. My question to you is, why are these distinctly different experiences, right? Shouldn't they be the same? As pharmacists, this is what we do, right? You integrate that distributive with patient care. They're not mutually exclusive. They talk about sterile and non-sterile compounding, a systematic approach for prescription verification. So what we saw in the community pharmacy APPE experience, it here at the University of Maryland, it's incorporated as evaluation criteria for health systems pharmacy. And with the prior authorization and assistance programs that we had talked about earlier. Okay, so now we're coming down to the next level. So in the curriculum, what do we do to prepare students? So the first thing that we're going to talk about is what are the requirements? So the American Council for Pharmacy Education, it's like the Joint Commission for Schools of Pharmacy and for continuing education. They have requirements that you have to meet and get surveyed. We had a virtual survey just not that long ago, but they're making sure that the schools are doing what they're supposed to be doing to train students. And so they have 11 different domains. We're going to be talking about the patient safety domain, which relates back to the EPA order fulfillment, right? So accurately dispense medications, some examples of the skills are listed there: accurately prepare and dispense medications, evaluate the appropriateness of a medication order, and sterile and non-sterile compounding. What are we doing? So again, we're coming down to the next level here. What is the University of Maryland's curriculum doing to address this? And very similar to the requirements, we cover sterile and non-sterile compounding. We talked about the difference between making an IV and checking an IV. We do product verification both for hospital and for community pharmacy. And we're going to talk a little bit more about EHR order verification. So we talked a little bit about this in the beginning, how students don't necessarily get that experience when they go out onto APPE rotations. But we have integrated this into our curriculum with a simulated electronic health record, and we have students verify both IV and oral medications. So here is an example of the electronic health record system that we use. I've been working with this activity for about 10 years now with Dr. Travato. We selected this specific product because it allows us to manipulate orders in all kinds of ways. So we can intentionally create errors for students to find, but it also simulates what you will find in the real world. And we follow this with education about things that you will see that are pertinent to medication orders in the real world. So we talk about every patient has to have an allergy assessment. We talk about orders must have an indication. There are no range orders. You can't have, take 1 to 2 tablets every 4 to 6 hours. You have to split those out. So we really kind of bring the real world elements into this experience. So when students log in, they're assigned patients. Over the years, we have really expanded what we have done with this. We started with three orders, and now we're up to 7 orders. So every student gets 7 orders. 5 of them are oral medications, 2 of them are IVs, and then they have to work through this process. So you can see in the status column, these are all non-verified orders. So they have to decide whether they're going to verify that order or not verify that order, but they're given a profile to look at. So again, you want them to get into the habit of looking at the whole profile at the beginning and at the end. So when you click on one of those orders, you get additional details like we see here. So for this, we have metoprolol succinate, and this might be a little bit nuanced in terms of the different categories of drugs that we look at. So we give them, things that can't be crushed. We give them wrong doses. We give them range orders. We give them drugs that they have an allergy to. Those are some examples of the errors. But on this one, you can see the dose is 50 milligrams. That sounds good, right? But it's a BID order. And you can see also that we have for hypertension. So there's an indication for the drug. We generally tell students the succinate formula is single daily dosing. They both start with S. So this should be a daily order. This would prompt a phone call to a provider versus the metoprolol tartrate, which is T twice daily dosing. So students like it, they can remember that easily. So in 2020, in the middle of the pandemic, we implemented IV orders. And so we selected orders based on their risk to the patient, based on ISMP criteria for safety and issues that you see in the hospital setting. They include electrolyte orders, antibiotic orders, and continuous infusion. So students get a tutorial about each of those things. They get a summary slide about what they should and shouldn't do. With the product that we use, there are no pre-builts. So you know how when you're verifying an IV order, you get a whole product, you know, fluids and dosing and everything is all in there for you. We don't have any pre-built. So everything that's in here, we've constructed for them. So you can see on the first line that this is a K-Writer, for lack of a better word, that this is a product that comes pre-made. It's a 100 ml solution. The solution rate is there. The indication is there. And so everybody that's looking at this order, would you approve this order? And I'm going to go to the next slide where the poll is, just to give you a feel for what we're doing in the curriculum. Okay, so we have 100% no. Oh, we got some yeses. Oh, people are waving off. Okay, so for those of you that said you would not approve the order, and I'm looking for PGY 1 residents, why would you not approve this order? I'll go back here and see if I can jog your memory. So what is wrong with the order? Oh, who said it? I can't see you. There you go. Give the man a coffee on us. So you can see there are a number of skills that students use, even though they don't necessarily realize that they're using those skills as part of the verification process. So they need drug information skills. They need to know if the solution is okay. They need calculation skills. They need to be able to calculate if the rate is okay. And so there's a lot going on in this verification activity. However, you all know that this is just scratching the surface, right? So we're not able to get to everything that is involved with an EHR order verification. Really, that is just, you know, the beginning basic level of order verification. And unfortunately, this class is in the fall of the second year. So there is a long period of time from the fall of the second year to the APPE experiences. And so I would say that perhaps students don't value the experience in the second year. What I can say with certainty is that students come back as a fourth year teaching student and they're like, this is the greatest thing ever. You know, I wish I had paid attention. This is what we're doing, right? This is what I need to know when I'm in the hospital. So we haven't so far addressed things like appropriate timing. So how do you prevent a patient from getting 4 or 6 grams of vancomycin, you know, within a 12-hour window? If you have a patient that gets daily meds and they're admitted at 4 p.m., do you give them the start dose, you know, today's dose, or do you wait until that order starts tomorrow? We don't have any clinical decision support. Nothing's in there for renal function. There are no flags that students get. There are no drug interactions alerts. And that was one of the things that we realized very early on, especially at this point where they have had very little therapeutics, that they would put all the medications in a drug interaction database and you would have this patient's on 2 antihypertensives, that's drug interaction. That wasn't really exactly what we're looking for. We're looking for clinically relevant drug interactions. So we had to pull that part of it out of the EHR and we run that as a separate activity just to give them a little bit more background and a more thoughtful process. And as I mentioned, we don't have any pre-built orders. So this slide here summarizes everything that we talked about. So we have what is in the pre-APPE curriculum, which is, you know, the curriculum, what is in the APPE curriculum at the University of Maryland, and what is considered an EPA. All of that is summarized here. Back in 2021, the experiential department moved towards utilizing the EPAs as the evaluation criteria. So in all of the required experiences, you will find the EPAs as part of those rotations. And that's reflected here on the slide, with the exception of order verification. So that's something that we have built into our experiences, but that wording specifically about verifying an order is not part of the EPA. All right. We're going to move on to competency and communication, but before we move on, are there any comments, questions about electronic health records, about your experiences in the health systems environment? Anybody online? All right. So a competency is different than an EPA, and we're going to show you that on the next slide. A competency is an observable ability of the healthcare professional, which integrates a lot of different things. So knowledge, skills, values, attitudes. And this, I think, clearly, oh, that's not it. Let's see if I can get this to work. Oh, it's going to work. So perhaps you've had students like this. I love it. Oh, how do I do that? Oh, no. Wow, we're gonna get the full experience. Gotta love the Devil Wears Prada. All right, I hope that stops. Let's see here. Yeah. Okay. All right, here we go. So we saw some of that in the first poll that we did about what we expect from students when they come out on rotation. And this isn't the slide I'm looking for. What happened here? Weird. So competency crosses multiple EPAs. And so you can see that here on the slide. There are 4 EPAs, and communication is the competency statement. So on the top, you have the actual wording of the EPA, but on the bottom part, under activity, you have the specific tasks that the EPA say that a student should be able to do unsupervised upon graduation. And so we're going to take a little bit deeper dive into this in terms of how we are meeting that as a school, but how we are also meeting that on the APPE experiences. All right, so as we did with the electronic health record, the essential elements valued communication, and you can see here that for EPA 4 and 6, this is covered in the ambulatory patient care and acute care essential elements experiences. So in terms of presenting a patient to a colleague, I left that one out. I'm sure you could open that up to interpretation. So I kind of look at this as the difference between a SOAP note and clinical documentation. We're not talking about a full formal patient presentation. We're talking about what does the next shift need to know about taking care of this patient? And those interactions are very different. And I would say that this is not something that we are currently covering in the curriculum, nor is it something that's identified by the essential elements task force. The lead a discussion on a recently published article, I left this as a gray area because what the essential elements say is that you should be using evidence-based medicine to base your decisions on. So you need to be current with the literature. And I think that's pretty obvious. But I interpret this as leading a discussion is a journal club. And the word journal club does not appear in any of these EPA statements or essential element statements. And yet this is something that we routinely have students do when they're on rotation, right? Okay, so we looked at the essential elements. So what does AACP say? Now we're looking at what does the University of Maryland say? So with regards to communication, we have that grouped with the interprofessional domain on our individual APPE experiences. And you can see it's the same, right? So it's the same as the essential elements. EPA 4 and 6 are covered, and we talked about the limitations, or I guess the nuances of 5 and 11 there. Now, looking at the curriculum. So what is the curriculum doing to get students ready with regards to communication? And this popped up on the beginning slide when we were looking at, skills that we want students to have. The standards say that educating a patient about a new drug or device falls under the domain of patient education. That seems obvious. Talking about drug-related problems or using appropriate communication skills falls under patient education and general communication abilities. Okay, so what are we doing? Abilities Lab is our skills-based laboratory curriculum. In the first year, so that's Abilities Lab 1 and 2, students are doing an introduction to a variety of experiences. They're doing community dispensing, they're doing IV product preparation, they're learning to counsel patients. They've had very limited therapeutics at that level. In the second year, in the fall, they get health systems skills, and in the spring, they get community pharmacy skills. So those are exclusive classes, health systems and community. In the third year, which is immediately prior to APPEs, in the fall, they have non-sterile compounding. So the majority of the course is non-sterile compounding. And in the spring, this has recently been converted to an APPE readiness course. And I'm going to talk a little bit about that because preceptors, we've heard you. We have heard from students, we have heard from preceptors about things that our students aren't necessarily prepared for. And so that was kind of the impetus for making some changes in that particular course. Journal Club was only covered in an elective course, interestingly. So ABL 6, which is the course right before APPE rotations, is now an APPE readiness skills-based curriculum. We have added a journal club. We were able to successfully do this in a relatively short period of time. So the concern is always grading and the amount of time that it takes. We paired up groups of students. We had them do a handout and an oral presentation. So we had both written and verbal communication skills. We picked COVID as the topic. So they evaluated some of the oral drugs that are now on the market. So it gave them kind of, new materials that hadn't been covered in therapeutics for them. Some of the feedback that we had, it was the first year that we've done it. Some of the feedback we had was the handout is not the real world. A preceptor wants 1 page. I would agree with that. We had them do 3-4 page handouts, not necessarily practical for what they'll be doing when they get out on the APPE rotations. And we also have worked in this particular class to kind of integrate the therapeutics knowledge with the skills of communication. So we evaluated them on their presentation on the verbal part of it, but we didn't evaluate them on the integration of those two. And so that's kind of something that needs to be worked on moving forward. Patient presentations to the preceptor. We've heard from a number of people that have said, it's just not there. Students have not presented before. Students are telling us that they have not presented before. So we have now had students working on presenting to a pharmacist preceptor at this point. One of the things that students are asking for is, can we create rounds? Can we make recommendations to a provider? Can we be in an interprofessional group? And understand better our role in that group. We haven't successfully done that yet. Totally open to suggestions. So, feel free to kind of share what your thoughts are on that as well. We've done telehealth medicine with COVID. It was kind of mandatory. We had students that had to do those rotations to meet the requirements back in 2020 when this all started to graduate. So we have introduced that to the curriculum. Many people feel that telehealth is here to stay. Once we get provider status, we are good to go. We've introduced patient education. We have focused on individual medications at this point. We have not focused on devices, which are actually covered elsewhere in the curriculum. And then SOAP Notes was like Pandora's box. So I don't know if it was a combination of the pandemic and virtual learning. We had students do multiple SOAP Notes across multiple weeks. They were longitudinal, they were multi-problem, and we uncovered a lot of issues. Now this gets into the written domain, but we uncovered a lot of issues that we feel need to be addressed. So things like multi-drug problems, or drug-related problems rather. That terminology was not familiar to students. Now we feel that the students have actually learned about and evaluated drug-related problems, but that term they did not recognize. And so we had to go through that, prioritizing problems, writing a note for multiple problems, and these are all areas that we're working on moving forward. So to wrap things up here, I would say that, I've made the case that there are gaps, right? There are gaps between what we're teaching students, what we expect from them, and what they actually know when they graduate. Are they practice ready when they graduate? Some of these are related to standards and the laws, right? So there are legal aspects to verifying an order or making an IV. And so students don't get that exposure. We could use simulated environments. We could be, introducing that, not introducing, but maybe reinforcing order verification closer to the time of rotation. We need to make changes on our end. And hopefully you have learned where some of the gaps are potentially on rotations. And so I'd like to end with, what are your thoughts about what you would like to see? So what changes would you like to see us make? I can't see that very well. What changes would you like to see in the curriculum? And basically, what did you learn from the information that was presented today? Yeah, I agree with this. The clinical practice experiences early immersion, I think is where it's at. And short of requiring students to work, which is certainly something we do not want to do we want to introduce those experiences to students earlier? Literature evaluation. We did work with the medical evidence course, and they kind of take a different approach. So it's not truly a journal club, but we did factor that in when we created that journal club experience. Mock rounds, I would love to do this. I think students would gain a lot of information, gain a lot of value from that. Yep, great. Yeah, we have had feedback from students about guidelines. We selected 2 this year. We did the COVID Journal Club, so that was new information, and the CHF guidelines had been updated. So we gave them a CHF case with the new guidelines to incorporate that. But depending on when the therapeutics are, and so right now, oncology is in the first year. By the time they get to the 4th year, that's like a lifetime in oncology, right? So there are, new guidelines and new treatments that come up just within the time frame that they're here. Move oncology to the later years. Excellent. This is really great information. Many of these things are things that we have thought about. The gray areas are kind of difficult. again, that's real life, right? Students don't like gray areas, right? They want to know if they're going to get the points or not get the points. So that makes that a little bit challenging. We tried to kind of introduce that idea in ABL 6, but there's still good ways to go on that. Well, this is great. Any comments or questions from the folks online in the classroom? Feel free to use your microphone, enter information in the chat box. Dr. Dev here is monitoring that. I'm happy to answer any questions or take any comments that you have.
Yeah, I have a quick question. Can you hear me?
Yep.
All right. This is Jimmy Leonard. So I came from Washington State, and
Cool.
the intern law in Washington State specifically says that you can do everything a pharmacist can do except for final verification on IV or parenteral products and supervise a technician. Is there any process in place to try to get the laws in Maryland changed to incorporate that? Because that would really make a change. And I mean, I knew people that were second and third years that were doing verification at, you know, one of the large hospitals in the state.
That is really great feedback. Washington State, as you know, is very progressive. And I'm not familiar with where we are with advocacy for interns, but I will say when I've looked at information regarding access to the electronic health record, nursing, PAs, and physicians all have statements that say, this is required for our students. They need to have access to the electronic health record and patient information for a successful experience. And so there is some room for pharmacy to advocate for these experiences, but that's really a fabulous idea. Thank you for sharing that.
Yeah,
Yes.
and I will say one other thing that I try to do when I'm precepting them is I say, you can at least save or pend orders, right? Even if you don't have access to, you know, sign the order. And I think that's been a surprise to some students, even well into their rotation, that they can do that. And so, you know, incorporating in that they can add them in and somebody else has to sign them is something that we can all work better on, and making sure they are well aware.
Excellent. And we have a comment here in the room, but I do want to say, I really think that we need to work as a group to integrate the distributive functions and the patient care functions. They are not exclusive. And you know, what I tell students all the time is, you cannot calculate the AUC for vancomycin that a patient didn't receive because it didn't come up from the pharmacy, right? So the bottom line is, that's our bread and butter. That's the value that we add to the healthcare system, and we should own it and not, you know, discourage it. Yes.
I'm just curious if anyone has in the EHR, kind of piggybacking off of what Jimmy was saying. I think back to like our medical fellows, for example, in the oncology setting, anytime that they sign chemotherapy, it requires a second attending signature. So that there's some background work done that for a learner, it would require like a co-signature or maybe a co-verification. And so if there was opportunity to give students access to verify an order, but it wouldn't reach the patient yet because it would still require a pharmacist to second verify.
I think that's a great idea. And, you know, there's like three major EHRs, right? You've got Cerner, you've got EPPE, and you've got Meditech, if that even still exists. So, you know, with basically three systems, you could really kind of address all of that. To my knowledge, because of our work with residents, you know, pharmacy residents aren't licensed initially when they come in, and that creates all kinds of problems. And they also can't verify orders until they're licensed. That the software, at least at our institution, and we're a Cerner institution, cannot accommodate that. So that's really a call for, you know, our HIT, overall pharmacy HIT organization, and also for the individual products to create that capability. But that's a fantastic idea. You're right. They do need two signatures. Did I see a hand up over here? No. Anything else? Well, thank you all very much for your attention. I know it's first thing in the morning, so that's a bit much. So take a few minutes and we'll reconvene at 11, right? do what you do.